Beautiful. I will now make you host. We go.
All right. Now I'm going to start the presentation, and just tell me whether you can see a single slide or whether you can see my presentation mode.
You can see a single slide that says Origins, A Tale of Two Patients.
That's it. Okay, good. So thanks, everyone. Just a little bit of a background. So I'm an orthopaedic surgeon based in Sydney. Main area of specialty is trauma, but still call myself a general orthopaedic surgeon. And I work mainly at Liverpool in southwest Sydney. I used to work at St George and Sutherland, but I'm also an academic and have done a lot of work on clinical trials and things like that. But where it started was researching workers' comp, and this is actually what got me into academia. And I did my PhD on the effect of workers' compensation on surgery. So it's something that's very close to me. So I'll just tell you how it started. I wasn't really told about the difference between workers' compensation patients and other patients when I was doing my training. And I did my training and I just thought all patients were the same. And it was only after I was a consultant and I started treating people that I saw two very different types of patients. And I could see two patients with the same injury with very different results. And to give you an example, I would see a lot of motor vehicle trauma. And in those days when I started practice, if you were injured on the way to or from work, you were covered by workers' comp. That's not the case now, but it was the case then. And if I had two young males with femur fractures, the one treated who was not under workers' comp and who needed to get back to work or study or whatever it was he was doing, the fracture would heal in the usual time. They'd be weight bearing on it fairly quickly. And I'd see them at 6 or 8 weeks. And if the fracture was healing, they'd go back to work and I'd never see them again. And that was pretty typical of treating femur fractures. But the workers' comp patients took longer to mobilize. And even though their x-rays looked exactly the same, it took them ages to get off the crutches. It took them forever to get back to work. They had more pain. And these were just sort of miserable patients with bad outcomes. So I couldn't work out why workers' comp patients had bad outcomes. And I spoke to people about this and they said, oh, you know, what are you talking about? And other people said, yeah, that's well known. So I decided to study it. And this was the first part of my thesis was a systematic review I published in JAMA in 2005. So this is going back a bit, and it was a meta-analysis of the association between compensation status and outcome after surgery. And so we found 211 studies that looked at the outcomes of a surgical operation. There's lots of different surgical operations, and divided patients by their compensation status. And 175 out of those 211 studies found that compensation status was associated with a worse outcome. 35 found that there was no difference, and 1 found that they actually did better. And for the ones we had numbers on, we worked out the odds ratio of a worse outcome in compensated patients was 3.79. And just to give you an example of that, there's lots of different operations, everything from sort of carpal tunnel, you know, any operation you can think of. But I just picked spine fusion here and spine surgery because that's been an area of interest of mine in particular with workers' comp. And it just shows you that whether it was a discectomy or a spine fusion, these numbers were pretty consistent. There's sort of odds ratio of roughly 4 times. And in fact, in many studies, the biggest predictor of a bad outcome was their compensation status, more than how severely injured they were, how old they were, or anything else. It was their compensation status which dictated whether they had a good or bad outcome. These are the broader results, and you can see we broke it down by lots of different things, by study type, and by procedure, whether it was shoulder, acromioplasty, carpal tunnel. We got fairly consistent numbers down here. And it didn't matter what the study design was or anything. It's all centered around that sort of 3 or 4 odds ratio. So this was fairly highly cited paper. In fact, it's still the most highly cited paper I've ever written. And so it's fairly well known that this is a problem. Now, this has been looked at by others. Here's another paper published much more recently, just in the last few years. And they found that workers' compensation was associated with twice the chance of having a bad outcome after surgery. And I spun off and did a couple of other separate projects, mainly looking at trauma. That was my area of interest. And we published at least half a dozen papers on this, looking at the effect of compensation on general health, on basically patient-reported outcomes after trauma. So we found that it was, consistently associated, but it wasn't always just their compensation status. There was other things we looked at, which is things like legal representation, because that was also associated with bad outcomes. And Darnell here is used to work at MAA. It was a PhD student of mine who took this on, and she did a systematic review looking at this in more detail and looking at patients who'd had injuries. And there was moderate to strong evidence of an association between both compensation status or legal representation. Both of them had a negative effect on physical and mental health. So why does this happen? And I think it's very complicated. I'm sure people in the audience have got their own sort of ideas and opinions on this. And I don't think that the science here is really settled, but there's certainly some things that have a role. So what is the role of litigation and this adversarial nature that is inherent in this system, where patients are trying to sort of maximize their compensation and insurers are trying to minimize it? That's an adversarial construct. That's probably got something to do with it. There's this, many of you may have heard of Norton Hadler, who's written widely in this space about the effect of compensation. And he says it's hard to get well if you have to prove you're sick. And so, these assessments, which I do on patients where we have to sort of categorize them and classify them as to how injured they are, it makes it difficult for them to get well, and they have to keep proving how sick they are. And if they don't prove how sick they are, they don't get any compensation.
Excuse me, Professor. Professor, I'm sorry to interrupt. May I please ask everybody to mute your microphone, please? Thank you. And
the role of fault and blame. I give this analogy to my patients, where the crushed toe analogy. So you can have someone who drops something on their toe. They could be at home doing some work and they drop a brick or a heavy weight on their toe, and they might have fractured the toe. Now that patient will be in pain. They'll have difficulty walking. They'll have difficulty walking, and they probably won't be able to go to work. But they will get better over a couple of weeks, and they'll go back to work, and they won't feel bad. They won't have any psychological problems, and they'll probably be off work for maybe 2 or 3 weeks, depending on the job that they have. Now, if the same injury, the exact same physical injury, occurs at work, where perhaps a boss leaves a loose piece of material at the workplace and it falls off the back of a pallet or something and it crushes the toe. It causes the exact identical physical injury, and yet this patient will report more pain. It will take them longer to get back to work, and they will blame the workplace. They'll say, I told the boss that they should have not stored those things there, and it's all his fault. See what he's done. And in order to sort of enforce the fact that he has been wronged, the worker will tend to complain of more symptoms. And often they'll be off work for many weeks. And even though the patient who injured themselves is still back at work at 6 weeks, and they will notice that they can feel pain, they're kind of like, well, that's okay. I can feel some pain there, but it's okay. I can still go to work. Whereas the workers' comp patient will say, see, there's still pain there. I can't possibly go to work because I can still feel pain. It's a completely different sort of psychology between something that you caused yourself and something that someone else caused. And it's got to do with this psychological concept called locus of control, how much control we have over things. So context is very important in determining outcomes. And most doctors know this. The outcome of a simple injury can vary widely depending on the context in which it was sustained. So that's why this kind of thing happens. So let's look more at the evidence. Now, I've published on this. This is a book I've published called Surgery, the Ultimate Placebo, and it goes on about the role of context in surgery, about patient expectations, what they expect to get, and how that influences the outcome that they have. And it talks a little bit about this compensation problem as well. So this is a more recent study. We published this, I think, last year in Pain Journal. And this just shows you, this is not so much about compensation, but this is a problem with the evidence we have for many of the operations we do. Sorry, there's auto timing there. And what we found is that a lot of the things we do, particularly in orthopedics, don't have very good evidence. And so a lot of the effect we see is due to this sort of contextual effect. It's not due to the operation being good or bad. It's to do with patient expectations. So we did this study where we looked at all the surgical trials on common surgeries for musculoskeletal pain. And we looked at the proportion of randomized trials that had been performed that compared the procedure to not doing the procedure. And the proportion of those studies that were favorable to surgery. And we defined favorable as statistically significant and clinically important difference in outcome. We also wanted to see how many of these studies were blinded. So we had a look and we found about 12,000 RCTs, but less than 1% of all the randomized trials done on common surgical procedures actually compared the procedure to not doing the procedure. So most of the trials that are done in the scientific world are looking at different ways of doing a procedure rather than looking at whether it works or not. But of the 1% of all trials that looked at common procedures comparing surgery to no surgery, only 15% were favorable to surgery. So 85% of them showed that surgery was no better than not operating. And yet these are the most common operations that we do. Only 9% of blinded studies were blinded, which shows you that there's a problem with possible bias in these studies, probably bias towards the effectiveness of surgery, and yet most of them were unfavorable. And of the blinded studies, none of them were favorable to surgery. So if you blind the patient as to what they got, they're much less likely to feel that they got better. So it removes that bias. And we looked at lots of different procedures again, shoulder arthroscopy, rotator cuff repair, carpal tunnel again, knee arthroscopy. But I just want to concentrate on spine because I think that's where a lot of the problems are. And this is the number of RCTs we found in this column. So we found 900 studies looking at spine fusion, whether it be in the back or in the neck. But of those in the lumbar spine, only 9 compared doing surgery to not doing surgery, and only 2 of those were favorable. In the neck, there were only 2 trials that compared it to not doing surgery, and none of them were favorable. We've also looked, we published this separately a couple of years ago, looking at the evidence for spine fusion. And this was a kind of review of reviews. And we found that fusion for degenerative disease and low back pain, we found 33 systematic reviews of only 4 trials. And these showed no significant advantage over cognitive behavioral therapy or an exercise program. So what these studies show us is that a lot of these operations that we are doing and we are paying for, and we're all paying for it, whether we're paying Medicare or workers' comp levies or CTP insurance, or we're paying Bupa or Medibank private, we're paying for these procedures. They're probably not effective. They're probably no more effective than non-operative treatment. So then we looked at spine surgery in the workers' comp setting. So keep bringing you back to workers' comp now. We published this recently. This was just published last year. And we got a lot of data from CIRA. So 9 years worth of data of all spine surgery performed under workers' comp in New South Wales. And we went through this data, and you can read this paper, and there's a lot in it, but I've just sort of highlighted what we found. So first of all, we had about 10,000 claims, and most of them were decompression. That's usual. Decompression is much more common than fusion, but fusion represented 40% of the cases, which is much higher than usual in non-workers' comp settings. So there's a lot of fusions being done. And some of the outcomes we looked at is the proportion that had returned to work in 24 months. Now, the idea of doing the surgery is to get people better, is to get them back to work, back to surgery, back on their feet, reduce their pain, etc. This was the return to work profile post-surgery. So we've divided up into two groups here. One group is fusion and one group is decompression. One group is decompression, and you can see that the return to full capacity here was 19% at 24 months for fusion, and better for decompression. And a lot had returned to reduced capacity, and a lot were not working. So the full capacity was very low at 19%, 2 years after the operation. And then we looked at the reoperation rates. Again, we just looked at 24 months because that's commonly been reported before. And we looked at any other spine surgery within that 24 months period under workers' comp. So this is probably an underestimate, because people who had fallen out of the workers' compensation system who needed further surgery would not be recorded here. So this is really a minimum number. And so we found on average it was 19%. So nearly 1 in 5 patients were having another spine operation within 5 years. We did a similar study on a smaller cohort published some time ago, which is this study here, which you can look up, published in the ANZ Journal of Surgery. And we looked at a cohort of about 450 workers' comp patients in New South Wales who had spine fusion and went through their medical records. It was a lot easier to do now because everything was electronic. Then we had to go into the insurance offices and pull out the records. But we found only 3% returned to pre-injury duties. So the job they were doing before at 24 months post-lumbar fusion. 89% of patients were still getting either major opioids or physio 24 months after their fusion. So the fusion is meant to restore function, relieve pain, and get them back to work. And you can see that it's just not doing that. So that's just some of the studies that we've done. And I guess in a nutshell, firstly, the evidence for many of the surgical procedures we do, not just in spine, but also in orthopedics in general, is lacking, and yet we still do them. And even in those studies, in those procedures where the evidence is not very good, the outcomes are even worse in a workers' comp setting across the board, and whether that be spine or whether that be even knee replacement. There's been studies showing consistently worse results in workers' comp patients. So I'll end it there and I guess take questions if that's okay.
Oops. Thank you so much, Doctor. Do you mind just flicking hosting back to me?
Yeah, I will.
That was fascinating. As a non-doctor and a person in this industry for a long time, those statistics blew me away, particularly in relation to how ineffective the fusion is proving to be. That's fascinating. People, if you would like to ask questions, now is your chance. Well, I can tell you, sir, that this occasionally happens. And
there's got to be one or two.
Got to be a question. Look, I've had 3 people ask if the recordings are going to be available, and I understand that you've consented to that.
Sure. Yeah.
Yep,
yeah.
beautiful. The times when there haven't been a lot of questions has been because the presentation is so good and so comprehensive that everyone's just kind of blown away. Let's leave everyone a moment if anyone wants to pitch in and ask a question. Here we go. Somebody's
So here's a question. So where is the happy medium between surgeons saying nothing else I can do for you? It's a very good question. And surgeons often raise this where they say, well, I've got to offer them something. And I remember having a conversation with a spine surgeon from the UK once, and he gave this talk and he said, spine fusion, it's not very good. It only works in whatever the numbers were, 60% of patients, for example. And we know that physio works in 60%, everything basically works in sort of 60% of people get better. And so it's no better than anything. So, we shouldn't be offering it. And then I said, but you're a spine surgeon. Do you do a lot of these spine fusions in back pain patients? He goes, oh yeah, I do it all the time. And I said, but why do you do it if it's no better than the alternatives? He goes, well, it works 60% of the time. So a lot of people surgeons in particular, have difficulty communicating non-operative treatments. A lot of what patients want is reassurance, because a lot of patients think that they have a very severe condition. And often if they're told, no, the changes you have are actually normal age-related changes. Most people have back pain intermittently. It can be well managed by, non-operative means. You need to sort of de-escalate things with patients a lot, because they often are catastrophizing, or they're thinking that this is the end of the world. They're going to end up in a wheelchair if they don't have surgery. None of that is true. So there's a lot of reassurance. Brittany's just clarified post-surgery. Well, I guess my argument is they shouldn't have had the surgery in the first place, because a lot of patients are worse off post-surgery. Because what I really haven't covered is the complications for surgery and failed back surgery syndrome and things like that, because surgery can make people a lot worse. And what ends up happening is, if they have worse pain afterwards, they end up having more surgery, which can sometimes make them even worse. So post-surgery, I guess the first thing is avoid it. Avoid the surgery in the first place, and you'll avoid a lot of the problems. But this is psychology. What these patients need is, they need a multidisciplinary pain management approach, to be told that pain is common, and that it can be managed, and it's not the end of the world, and it will not cripple them, and all these other things. And not just nothing can be done for you. That's not really an appropriate answer, or put up with it, that kind of thing. I might just skip on to some of the other questions, if that's all right, Michelle. Yeah. So the next one is, why do you think the decision makers in the compensation system are so reluctant to accept your findings? Almost always accept it. Exactly. So the very good question. It's very difficult to challenge the surgeon's decision. If a surgeon says they need surgery, and a claims manager says, I'm not sure that you do, the patient's kind of like, well, you're just saying that because you want to save money. And where's your qualifications? You're not a spine surgeon, et cetera, et cetera. So you're kind of like, it's difficult to match. The insurers do not want to be seen as the bad guys, and they see themselves as being good guys by giving the patient the benefit of the doubt and saying, well, we're not sure that it's going to work, but gee, we want to offer you, something. And if you want to have it done, then okay, we'll approve it. I think that's the wrong attitude, because the patients will often end up worse with that. But the insurers sometimes think they're being the good guy by allowing that. And it's wrong. There's ways around it. And in Queensland, for example, if somebody recommends spine surgery, the insurers say, okay, that's fine, it'll now go to our panel. And it goes to a panel of spine surgeons who look at it and say, there's no way this patient needs spine surgery, we're declining it. And the surgeon will be less likely to challenge a group of senior peer spine surgeons who've gotten together and said, this is unnecessary surgery. And so they'll back off, and then next time they won't request it. And so that's one way of controlling it. There's lots of other ways that have been tried. Second opinion is the other thing. There's been a great study from Brazil where they got all these patients who were recommended to have spine surgery and got them a second opinion. And I think in most of the cases, the second opinion said the surgery wasn't necessary. This is from other spine surgeons. So it just shows you what is out there. And in fact, I think in a certain proportion of the cases that they looked at, the condition that the patient had wasn't even a spinal condition. They found it was something else. So there's lots of ways we can avoid this surgery. Can I comment on people being offered, let's go in and have a look around, see what we find for arthroscopy? Yes, that shouldn't be done. It's not necessary to do a diagnostic arthroscopy. An MRI can tell you just about everything that an arthroscopy can. An arthroscopy will not help degenerative conditions in the knee. That's been very well proven, and yet it's still commonly done. It shouldn't be approved. That's all I can say. The next one, the further surgery 24 months later, did that include surgery to the adjacent different levels? Yes. So we did break that down to look at it, but it's difficult without getting the actual operation reports out. And so what we did is we just said, have they had another spine operation? And it could be a different area of the spine. It could be the exact same area of the spine. It could be the next level of the spine. It could be a disc replacement. It could be another fusion. It could be a decompression. But it just, did they have another spine operation? And the reason I did it like that is because, well, if somebody's got a spinal condition and you're addressing it with, say, a spine fusion, you should address what they've got. I mean, whatever you've done, they shouldn't have to come back to have something else done within 2 years, because that's a sign to me that you didn't do it right in the first place, or you've missed something. It's not acceptable that a patient should have revision surgery after a knee replacement. I mean, if you do a knee replacement, it should stay in there for 20 years or whatever. And if you're coming back early, there's something wrong. The outcomes for disc replacements are about the same as the outcomes for spine fusion. That's been shown elsewhere in other studies and randomized trials and things like that. So disc replacement doesn't offer a whole lot more over spine fusion, despite the theory behind it. And again, it's largely because a lot of these patients have pain, which is not related to their spine. These people are having spinal surgery for changes seen on an MRI, which are present in many asymptomatic people. So that's why the surgery often doesn't work. And the last comment is, money is the culprit. Injured workers get surgery paperwork over surgeons happy to do the surgery. Yeah, I think that what happens, so we did another study, which I haven't shown here, looking at the comparative rates of spine surgery in the private setting compared to the public setting. And we found that it's far more likely to be done in private, and it's far more likely to be done in workers' comp. And we're repeating that study at the moment. So if a surgery is funded, it's more likely to get done. And I think the mentality of the spine surgeon is probably something like someone comes to them with back pain. If they're not insured, it's kind of like, well, there's not much evidence for spine surgery. We don't know that it does any better than non-operative things. And I know you've tried non-operative things, but really it's not, I can't justify doing surgery on you because we really don't have the evidence that it makes much of a difference. So they will treat the public patient non-operatively. If a workers' comp patient comes in with identical MRI scans and an identical kind of patient, they might say, well, again, we don't really have much evidence that spine surgery, that fusion will actually help you. But it does help some people. And, we won't know until we try. So why don't we give it a go? And there's also other things pushing them. I mean, people are more likely to have investigations and multiple investigations if they are workers' comp, and therefore they're more likely to detect things that surgeons will operate on. There's been some interesting studies done showing that if you just do an MRI on someone, they're more likely to get surgery. They've had patients where they randomized them to a plain X-ray or an MRI, and they looked at the outcomes 12 months later, and the back pain was exactly the same between groups of patients, but the people who had the MRI were more likely to have had an operation in the meantime. So there's lots of things driving this, but the industry drives this. It's in the interests of the device manufacturers, it's in the interests of the surgeons, it's in the interests of the hospitals, it's in the interests of the imagers, the radiology practices, to do this, to have surgery.
Prof. Harris, we've got one last question. Do you have time to answer that?
Yeah, so increasing trend to do 2-stage spinal surgeries 6 months apart. Yeah, and there's no benefit in doing anterior or posterior or anterior and posterior. It just doesn't matter. It doesn't make any difference to the outcomes. The outcomes are bad. Surgeons get focused on techniques, and that's why I showed you. We found 12,000 RCTs on surgery, and less than 1% of them actually compared doing the operation to not doing it to find out whether it worked or not. The other 900 RCTs we found on spine fusion were things like this: doing it through the front versus the back, this rod versus that plate, 2-stage versus 1-stage, disc replacement versus disc fusion. And none of these things seem to make a difference because the operation probably shouldn't be done in the first place for a lot of the patients. So no, I don't. Why is there increasing trend to do this? Because it's the latest fashion. The surgery just goes through trends, that's all. Surgeons think that that's the way to go now. Well, some surgeons do, so they do it. Other surgeons see that and they think, oh, I should be doing that as well. There's no science really behind a lot of the fashion in surgery, unfortunately.
Wow. Look, thank you so much, Professor Harris. I know you've actually got another appointment to go to now. This has been particularly well-attended seminar, so we thank you very, very much. And to those of you who've attended, thank you for your time, and you will receive a copy of the recording in the next couple of days. Thanks again, sir. Go and have a great rest of the day, and everybody else as well. Thank you.
Thanks very much, everybody. Goodbye.
Bye.